It's a pleasure to be here. It's been great to see a bunch of old friends, great to make a bunch of new friends, some in person, some on the computer. And when I thought about doing this, I came up with this talk. It's a sort of a compilation of some thoughts that I and we have had on organ support, and it'll marry with the talk later this morning about resuscitation. And it's really a story. It's about an entrepreneurial and investigative spirit, and it starts with the advent of critical care and kind of goes through its maturation. It started a while ago, and it's not over by a long shot. So indulge me a few minutes, and we'll walk through some of this. And if we go back to this concept of multiple organ failure, if we go back to World War I and World War II, cardiovascular failure was organ failure. It was shock. As we got better at this, kidney failure became more prevalent at the end of World War II, and shock was solved because we actually had IV fluid. So people that died now survived. The lung becomes a limiting organ in Vietnam, and then blood banking and helicopter transport saved many people, and lungs and kidneys start failing, and dialysis is invented. That sort of supports the kidneys. But at that point, this idea of respiratory failure was brand new. And I still remember being a young resident and walking through a bunch of the work that ultimately led to our understanding of ARDS. Now, it's remarkable. This is Art Bowie's description of multiple organ failure. Remember, this is 50 years ago, and it's pretty good, right? It's a progressive sequential organ system failing after injury or operation. It's shock, it's ventilatory failure, it's renal failure, it's hepatic failure, in that order. GI failure with metabolic failure. And he said the interrelationships and dynamics are difficult to understand, still true. He said that the way to do this was early ventilatory support, avoid fluid overload, avoid excess sodium, filter blood before transfusion, ventilatory therapy, cardiac output, not blood pressure. This is 1975. And empty the stomach, keep it empty, and neutralize the acid. Controlled ventilation after operation, maintain renal blood flow, dialysis early nutritional support, antibiotics, and drain sepsis. That's a pretty comprehensive look at multiple organ failure, and it starts 50 years ago. And I came up with this schematic. This has got to be 30 years ago. And this is still my understanding of how this works. You get a terrible injury, and you just die, right? These are the people, we used to say they came in with a pH of 6.8, but now people with 6.8 live. So I don't know what the low number is, 6.5 now, something. And those people just never get well, right? They die usually within 24 hours, and none of their organ systems work. On the other side of the slide is what we used to call organ failure. And we used to pat ourselves on the back and say, boy, aren't we good at this? But their organs didn't fail. They just weren't working very well. And if you just took good care of that patient, then a day or two they recovered and they were fine. But it's the group in the middle. It's the people that turn on the organ failure cascade, like Dr. Bowie said. And once that gets turned on, it's hard to turn it off, and their organs sequentially fail. And while the lung is a complicated organ physiologically, anatomically, there's not much to it, right? It's got air, it's got blood vessels, it's got alveoli, it's mostly air. And so it has a limited ability to express itself. When the lung gets unhappy, it leaks. It leaks and it collapses. And so respiratory failure kind of looks the same, and we actually care for it relatively similarly. We can go back to 1946 in World War II. And again, the descriptions are really pretty good. Dry lungs were okay. Wet lungs were hard to resuscitate. People with wet lungs were poor operative risks. They got sick. And the mortality was highest in people with concomitant chest injury and respiratory failure. And they defined wet lungs as mucus, blood, or serum in the pulmonary tree. Now, ARDS, as it was ultimately called, really gets jump-started at the University of Colorado. And a guy named Tom Petty, as I always smile and say, without the heartbreakers, joined the faculty at Colorado. And his recruitment package was that he got a blood gas machine. This was a big deal, right? So it came in a box. I read his account. He took it out, he put it on the floor, he put the blood gas machine together himself. And he met this guy, Dave Ashbaugh. Dave was a surgical chief resident. And they found an Engstrom ventilator in the basement, and they just opened the box and read the directions. And so they had this guy with pulmonary contusions, and they put him on 10 of PEEP, right? That was a big deal back then, 10 of PEEP, right? We're not even getting warmed up. Now it worked, but the patient still died. And they recognized that after a few patients, that what made them different when they had this, quote, sudden diffuse and symmetrical pulmonary infiltrates, found unrelated lung insults. This is an Engstrom ventilator. This is what was used in shock trauma for years and years and years. You know, it's as big as a patient's room now. And they reported on 12 patients with 5 survivors, 40%. They sent it to the New England Journal of Medicine and JAMA, and it was immediately rejected with, as Dr. Petty said, scathing criticism. As the reviewer said, everybody knew that PEEP was bad for you. They sent it to Lancet, and Lancet took it in two weeks and published it as the lead article without delay due to its importance. And it was read by the guys in Vietnam. And Ben Eisman from Colorado convened a conference in Washington, the pulmonary effects of non-thoracic trauma. Concepts were adopted by the military. The guys came back from Vietnam. They went into civilian practice. And at that meeting, Petty reported on 21 patients with 10 survivors, right? 40 to 50%. That's the constant number for survival back there. This is the article, and it's sort of cool to look and realize that one of the seminal papers that describes a new disease is written by an assistant professor 1 year out, a chief resident, and a couple of fellows. Don't tell me it can't be done. And in 2001, reflecting on this, Dr. Petty said we were in the right place at the right time. We had modern technology, then blood gas analysis, next to the patients. We did them ourselves. We noticed what was different. We were not bound by conventional thinking. We challenged dogma. We flew by the seat of our pants. As physicians and surgeons, we worked together. And we sort of got it, right? Over the years, we began to understand that this respiratory failure was a cascade. There was either direct lung injury or an injury or problem away from the lung that activated the inflammatory response, upregulation of white cells, preferential attraction of these white cells to the lungs, plugging of the white blood cells in terminal alveoli with release of toxic substances, loss of capillary integrity, interstitial hemorrhage, hyperventilation to maintain minute volume as they developed interstitial edema. And then the things that came were non-cardiogenic pulmonary edema, loss of surfactant and alveolar collapse, but hypoxia comes relatively late. And in people that lived, they got secondary inflammation. We called it pneumonia for a while, and then they healed by fibrosis and remodeling. And this is some work from a guy named Barry Fowler. Barry was my chief resident when I was a medical student. He's the reason I liked taking care of sick people. And this is his work. And you can see that it doesn't show up for a day or two after the insult, right? Sometimes 3 days. And the survival, 40%. The number doesn't really change. And we sort of defined this, right? It said it's bilateral infiltrates, it's hypoxia, it's not CHF, whatever that was. And you had to be able to identify an inciting cause. And this was the chest x-ray that all of us got used to looking at. And we worked our way through trying to take care of that. Well, mechanical ventilation was obviously our friend here, and Joe Civetta in Miami was the guy. He was the person that taught us most of what we knew. And he believed, and we believed, because Dr. Civetta said it, that high driving ventilator management with PEEP was the way to go, right? PEEP kept the alveoli open. We were so stupid, we actually thought that the PEEP drove the fluid back into the blood vessels, right? And that's what we said. We didn't know enough to know that was wrong, because the x-ray got better instead of recognizing we were just over distending the good alveoli. And the rule was you kept going up on PEEP until you got an intrapulmonary shunt fraction of 15%. Everybody had a PA catheter. And we used volume to support cardiac output. Anybody with more 15 PEEP got prophylactic chest tubes. My record of PEEP at a guy with a ruptured abdominal aortic aneurysm was 55 centimeters, which is what it took to get me to get an intrapulmonary shunt fraction of less than 15%, because that's what Dr. Civetta said. The peak airway pressure in that guy was over 100, and he didn't die. I have no idea of why not, because we sure took a shot at killing him, but that's what we did. Now, the recognition that there were different kinds of lungs with ARDS, or respiratory failure, was really came to be when, and I think the Italians really did this first, they harnessed the power of CT scan. So we began to realize it wasn't, not every alveoli was affected the same. And you guys are very familiar now with CT in patients with respiratory failure showing some sick lung and some lung that's not so sick. And we have worked through all of these different ventilatory strategies as the way that we're going to ventilate people with ARDS. Everybody's got their champion. I'm from shock trauma, so it's APRV, it's APRV, it's APRV. And it's a perfectly good way to ventilate people. But despite years and years and years of trying, we can't show that one's better than the other. Now, what we did show was that 6 cc's tidal volume was better than 12. That was very clear, right? And so lung protective ventilation becomes a thing. But this is a review up through about 15 or 20 years ago, and the mortality hasn't really changed. It's got a little better, I get that. I mean, we're a little better than we were in 1980, but we're not a hell of a lot better than we are, because once you get established organ failure, it's hard to turn that cascade off. Now, the sort of the new kid in town, and maybe this will turn out, I think it will, is mechanical lung support, right? So this is ECMO runs, and you can see somewhere around 2008, it goes up like that. And so sort of lung dialysis, if you will, using a machine to replace lung function becomes a thing. And there is some data that says that in certain patients, it's probably a good idea. This is the H1N1, and it was interesting. It wasn't that going on ECMO saved your life. It was getting transferred to some place that did ECMO. Maybe better understanding of the disease. And then this data from 2009, where ECMO, in fact, was associated with better survival. All right, so we have this sort of concept of lung failure. All right, well, the kidney's sort of the same, I think, right? It works too much, high output ATN, and doesn't clear toxins, or you develop anuria. The liver does the same. It's about failure of organ performance. Now, we didn't have dialysis for many, many, many years, right? The first working dialyzer is about 80 years old. The first person was treated in 1945. And after World War II, this guy, William Kolf has a few dialyzers, he spreads them around. The first person is started on hemodialysis in 60. Quinton, who actually was a guy, the catheter guy, and Scribner make shunts so that you can actually do this out of the hospital. The thing that happens is everybody with renal failure ends up with health insurance. So dialysis now becomes a thing. Well, what about acute renal failure? Well, CRT becomes a thing. And this is in the early 70s. Kramer developed CAVH in 77, but we need to clear toxins better. So we go to CVVH and we get hemofiltration combined with dialysis. But we're still having trouble, I think, defining what renal failure is. We use parameters that are relatively easy to measure, but how much does this really have to do with the kidney's ability to work? A little bit maybe, but I don't think it's absolute. And we worked through this when I was in New York, and then when I get to Baltimore. If you're going to do hemodialysis, you need a nephrologist, you need a machine, and you need a tech. And we said, but that's not going to work in unstable patients because we give them more volume to support their hemodynamics when they're on dialysis. They have marginal blood pressure, they don't clear their toxins. We have the same conversation with the nephrologist the next day. So CRT said it's got to be better, right? It's a 24-hour cycle. We did our own, so we didn't need a nephrologist, we didn't need a tech, we owned the machine. And we said, well, it may not clear toxins as well, but better hemodynamics and 24-hour care will make this a better idea. And we believed it and believed it and believed it until we tested it and have been unable to show that CRRT is actually better than dialysis, intermittent hemodialysis. Now, in the series, there was some good news. Some people recovered renal function in several of the studies more reliably with CRRT, but there was no overall hemodynamic effect in most of the data. Some of the data said, yeah, there's better hemodynamics, but no differences in splanchnic perfusion. So well, that's because the patients are mostly medical. There aren't any trauma patients. And we talked ourselves around this issue because we're still sure that CRRT was better than IHD. We just couldn't prove it. Now, it may be that the issue is not so much what modality you use, but when you started. And this is some data we wrote 23 years ago now. And you can see our survival gets better over people. They start on CRRT, but it's the early starters that live. The survival is substantially better in people, and I mean early. This is like BUN 30, creatinine 1.5. And so it may be that early starting, and we'll come back to that concept. We go through a new classification scheme to try to be able to be sure we're comparing apples and apples, and maybe we are. And liver failure is sort of a recurring theme here. We don't really have a great way to measure liver function. The biochemical parameters aren't very specific. We didn't have a way to fix liver failure. We didn't have a thing. And mortality for hepatic failure was 80%. And just like respiratory failure, it just did not budge. But some technology emerged. There's single pass albumin dialysis, there's MARS, and that's what's available in the United States. And MARS is an albumin dialysate across a permeable high fluid membrane that removes protein-bound substances. We always marry it with CRRT to remove water-soluble substances. The FDA approved it for a couple of things, but it wasn't approved for chronic liver disease. It wasn't approved as a bridge to transplant. Great. Once again, I did not break it. And it wasn't really approved for acute hepatic failure other than for drug overdose. And here's the index case. There's this young kid, we talked about this yesterday, I guess. This young kid came in. His friends played a trick on him. He's a construction worker. And they failed to tell him that the building they were working in was going to be demolished the next day. So he goes to work and he's sitting there looking around going, where the hell is everybody? And the wrecking ball comes through the wall and hits him in the epigastrium. This was bad. There's his CT scan. So that's too bad. And we take him to the operating room. We put him on venous bypass because we know this is going to be awful. This person back here, that's Deb Stein. You can see Dr. Stein is carefully supervising me. And I put my hand behind his liver to mobilize it, and his whole liver comes out. It's avulsed off the cava. That was not so good. So we did a total hepatectomy. I didn't know what else to do. And we did a portacaval shunt to decompress his mesenteric circulation. And he had a crush injury to his, the head of his pancreas. We did a Whipple. And he lived. And so I called the transplant guys. I said, what do you think we should do? And turns out that if you don't actually have an anatomic liver, you are #1 on the list in the country. All right? I mean, who needs a liver more than this poor kid? And he wakes up. So we're trying to bridge him to transplant. And we get a liver. The family then says no. We get a liver. The arterial system's no good. We have to wait 3 or 4 days. And we just keep giving him albumin and keeping him on CRRT. And he gets a liver, and we actually hook him up, and he ultimately dies 3 weeks later of sepsis. And I said, boy, if we could have done better, maybe he would have lived. And I never forgot that. And then the next guy comes in with a terrible gunshot wound, right lobe of the liver injury. He gets massive transfusion. We embolize him. He gets major hepatic necrosis from, I do a right hepatic lobectomy, and he develops acute liver failure. And I look at him and I say, we can't have another one of these kids die. So this is a true story. I go down to my office. I'm scrolling through this, and I say, Mars, wow, that would work. So I called the company, and I say, I need a machine. How about today? And they say, this is crazy. There's this machine that's on a truck. It's on Route 95 in Maryland going north. And I say, turn it around. We'll take it. And they say, fine. So they turned the truck around, and I said, oh, I guess I have to pay for this now, don't I? So I walk into my chief operating officer's, who has been with me now at that point for 10 or 15 years. And I say, I need a thing. And she doesn't even look up. She says, what do you want? I said, I need a Mars machine. She said, how much does it cost? Actually, I have no idea. She's still not looking up. She gets on the computer. She says, 25 grand? By your standards, this is cheap. No problem. And it shows up. We take it out of the box. We put it together. We treat the guy. The engineers come up and bless it. Okay. We treat the guy, and he survives. He recovers his liver function. We follow this with 2 people, 2 athletes. One's a college football player, one's a triathlete, who both get hyperpyrexia and multiple organ failure. When they biopsy the liver, they have no functioning hepatocytes. We put them on Mars, we bridge them to transplant, and they both live. And I say, well, I think we got something here, right? This is the series we presented at the American Surgical. It's 27 people. You see, it's a sort of a potpourri of etiologies. The bottom line is that if you look at most biochemical or hemodynamic parameters, at least the parameters get better. It turns out that some things do better than others. trauma does okay, but bridge to transplant does really pretty well, 80% survival. And this is the sort of the published indications, right? It's not liver failure from multiple organ failure, reversible fulminant hepatic failure, acute toxicity. It's made for Tylenol overdose. And hepatic encephalopathy is the strongest indication. These are the contraindications. If you can, all of those make some sense. And now there is more data that is emerging that says that maybe this is a good idea. This is just a couple of months ago, people treated at acute liver failure study group centers. They were propensity score matched. And the thing that predicted 21-day transplant-free survival was Tylenol overdose and the use of bars. And so in the same way, we were at the right place at the right time. We had different modern technology that we controlled. We noticed what was different about the patients, and we weren't bound by conventional thinking, right? We challenged dogma. We flew by the seat of the pants. We got everybody in the room and said, first, how do you put the damn machine together? And then how are we going to use this? And it worked out really pretty well. Now, this concept of mechanical support, which I think is a great concept, both as an organ replacement therapy, and we'll talk at the COT meeting why I think that mechanical support is actually a resuscitation strategy. As I thought about this, I went back to the late 1980s when I was in New York, and I became progressively frustrated by what I perceived to be a lack of interest by the Kings County nephrologists taking care of sick people. They just didn't want to be in the ICU. And trying to get them to dialyze somebody was painful. And I would laugh and say, you needed uremic frost before they would bring the damn dialysis machine over. And so I got mad and I went over to the MICU one day to try to find one I could yell at. And I saw a CAVH machine sitting around. I said, what's that? And somebody said, well, it's it's this continuous dialysis machine. So I did the only reasonable thing. I stole it. And I brought it back over to the surgical ICU. It didn't really seem very hard to use. It's pretty simple, actually, compared to the circuits we use now. So we just started using it for people with renal failure. The nephrologists wondered why we'd stop calling them. They came over and said, that's our machine. But one of my enterprising residents had a machine shop and had put a little plate on it that said property of the surgical ICU. So no, that's ours. So I'd love to give it back. And we started wondering what else this would be good for. And these two people, we'll go back. That's Roxanne Todor, who's now a neurosurgeon in the Bronx. She was a medical student. And Fernando Garcia, who was an aspiring cardiac surgeon, he was a PGY2. They said, we've got this idea. And we started using it for patients that had respiratory failure, but not renal failure. This is from the publication. It's not a very complicated thing, right? It's just a cylinder, the blood goes in, the dialysate goes the other way. And what we found out was when we put this on sick people, they got better, but they didn't have renal failure. Their cardiac output went up, their oxygen consumption went up, their FiO2 went down. And in the people in which it worked, it was sort of magic, because we put it on and we would sit on the floor and just watch the stuff drip. And when you would look up and you'd see their blood pressure started to get better 15 minutes later. And then they would stop soaking up fluid. And then we could take fluid off of it. And I never exactly understood why, but my theory was that we were dialyzing the inflammatory mediators, and that helped us stabilize the membranes. But I never proved it. But isn't that what KCI tells us that the Apthera does? Isn't that what DPR is supposed to do? Maybe we had something there. Maybe that there was some magic in the coil. And so the same thing. We were at the right place at the right time. We had modern technology that we controlled. We noticed what was different, and we weren't bound by dogma. We flew by the seat of our pants. We got everybody in the tent, and we just made it work. Now, as you try to generalize this, one thing that if you want to do organ support is you need to be able to get the patients into the hospital, because this is a transfer business, right? Much of the time. And so what we did, this is the new tower we built, I don't know how long ago, it's probably 8 or 9 years ago now. It's a beautiful, I don't know how many gazillion dollars it costs, but it's many gazillion. And what we did is we conceptualized organ support and critical care, and I built the critical care resuscitation unit. It is the only ICU that I know of in the United States. The only way you get a ticket in is if you're a transfer originally from another institution. And if you're going to do that, this was, if you've been to the shop, this is the non-trauma version of the TRU. And if you're going to staff that with people, who would you staff it with? Well, you want people who are going to be able to move people quickly through a system that know critical care, because you come in, you get your evaluation, you leave, and you go to the ICU where you're going to live. So he said, I know who does that. Well, EM critical care. So I hired a bunch of emergency medicine critical care people, most of whom we had trained ourselves, and we went into business. In 1 year, we doubled the number of critical care transfers, 6 beds. And there was a 2/3 increase overall, doubled the number of surgical critical care people. We reduced the amount of time, and we did this with a 4% increase in the total ICU bed capacity. Made sense. And then we opened a lung unit. The only thing this lung unit does is VV ECMO. And we went into the lung dialysis business. And we believed that if we put them all in the same place and had nurses that only did that, and doctors and fellows that were dedicated to ECMO, that it would be better. It's staffed, the guy that runs it now is Ali Tabatabai, and we married medicine and cardiac surgery and our group. These are just some of the early results. We started small with 50 patients in a year, but you can see they were pretty sick. They were on for a while. Survival was 71%. There's a theme, will be a theme here. And it was better than it was when we didn't have the dedicated unit. And that, 8% got Mars, 2/3 got CRRT. These are the 2020 numbers. And you can see that the survival, pretty good. Same thing. This is pulmonary, this is cardiac, this is eCPR. And relative to ELSO, our numbers compare very, very favorably. This is our COVID ECMO numbers. We had the second largest series in the world, the largest series in North America. The only people that did more was someplace in France. And our survival is 65%. ELSO survival is about 50%. So I'm willing to say that dedicating this really made some sense. And so now we've got this concept of resuscitation, organ failure, temporary mechanical support as a bridge to recovery or a bridge to death. But the new wrinkle then is, how about organ support as a bridge to transplant? And maybe we're not thinking broadly enough. This is a patient on ECMO in our unit. We get them up and walk them around while they're on ECMO. Everybody says you don't do it, but it's not true. In fact, we do it. That's the little rig we constructed so that we have ambulatory ECMO. And that's Bart Griffith, is one of the cardiac surgeons, and that's his gizmo, because he is going to, in the not too distant future, I think, have a commercially available portable ECMO unit, and people can now go home on ECMO. And how about xenotransplantation, right? As a bridge. Well, it's a thing. The early results weren't very favorable, and we said, I don't know, tolerance is going to be a problem, but you don't need it to be permanent, right? And Starzl, who was an incredibly bright guy, but was bounded by no rules, just started doing them. That's not very well publicized. There's one of his publications when he put a couple of, I think, baboon kidneys into a human. This is a series from 2000 of extracorporeal support. And most of you know that we did the first xenotransplant, cardiac transplant, a number of months ago. The guy only lived for 2 months, but he lived for 2 months. Yeah, there's a certain proof of concept here. Now, mechanical support as both resuscitation and organ support is a concept I don't think we've embraced enough. This is a guy that came in, he went to work, he went out with his friends Saturday, he didn't show up for work Monday, he got found at the bottom of the steps Monday evening with a temperature of 75 degrees and no vital signs. He got airlifted in, and he arrested on the heliport. He presented with CPR. And we did 90 minutes of closed chest CPR and cannulated him for ECMO to both warm him and to support his hemodynamics. Now, most people think that I'm not very smart, but I could see everybody rolling their eyes as we're doing CPR, like, the old man has lost his mind. What are we doing here? We warm him to 35 degrees. He fibrillates. We cardiovert him. He comes back, and he has left-sided compartment syndrome, but he ultimately gets weaned from ECMO. It turns out that the reason that he was on the ground was he fell down and had a thoracic spine fracture with a deficit. Hard to argue. He's back. He's an engineer for Lockheed Martin and is back working. I just talked to his sister a couple of weeks ago. And I think that what this is about is it's about preventing right heart failure. You guys in medical school get taught that right heart failure is from left heart failure, but I'm going to tell you it's the other way around. Left heart failure is from right heart failure. These patients come in, they have increased pulmonary vascular resistance, their catecholamine levels are through the roof. We put them on a ventilator, we turn the ventilator off, and they have decreased venous return, and their right heart fails. It bulges in an intact pericardium, and the interventricular septum shifts to the left, and the left heart fails because the right heart has failed. We're looking at the wrong side of the heart. But if you put them on ECMO and you turn the ventilator down, then you have helped treat that. And I'm going to tell you, Roboa is an organ support catheter. It supports cardiac output. And we'll talk later about EPR as a resuscitative technique, deep hypothermia. It's a cardiac support technology. And our new toy, which is selective aortic arch perfusion, is the same thing. It's got a lumen so you can deliver blood and drugs directly to the heart. It's about cardiovascular support. And so we've now got this arc of resuscitation and cardiac support, where you get a menu of options. Now, we said earlier that everybody used to be, anybody with a pH less than 7 died, and now they don't die anymore, right? Our current in the ICU salvage is a guy that came in at 6.65 and is still alive. He's not doing great, but he is in fact still alive. And so we are seeing new organ failure. This is a kid that came in with a gunshot wound. You see his hemodynamics. He had shot his GDA off of his porta. So that was a little complicated to try to get fixed. And the clamp was out a long time. He went through 40 units of blood in his first operation. He has 4 operations in 36 hours. And he ends up with this profound liver failure, right? Usually our approach is they get 3 runs of Mars and they're done. We gave, this kid's 22, I gave him 14 runs of Mars and he just wouldn't get well. There's his CT scan. I go, I mean, it's not the worst looking CT scan, but he just won't get well. Should he get a liver transplant? I said, yes. Transplant guy said, oh, that's a high risk case. Yeah, it's a high risk case. Did I say he was 22? And he died without a liver transplant. Should he have? I don't know. I mean, there's not right and wrong here. And it's easy for me to say, right? Hey, just put a liver in him, all right? But he didn't get one. This is a kid that came in relatively recently, came in with a pH at 6.9, base deficit minus 22 with a gunshot wound to his right groin, 2.5-hour tourniquet time. He got shot out in Western Maryland. And by the time we flew him in, we put a right groin Reboa in, we fix him, and he has transaminases that are 3,500, 7,000. His bilirubin's 20. We do a liver biopsy. Now, he doesn't have anything wrong with his liver other than shock. I mean, what do you do with this kid? What's the right answer? We didn't do anything. We didn't put him on Mars. We didn't transplant him, and he got well. So I don't really know. Now, I also think that it's important to recognize the ethics that are involved with these things. I mean, there's no conceptual framework. This is crazy stuff, right? So what is ethically sound and what is not? I'm not sure. This is some statements from something that Sarah Murthy and I wrote in 2015, where we said it's not about playing God. It's recognizing that we're not God. There's a limit to there's no limit to what we can do. There is a limit to what we should do. And, you know, I think that we need to check our egos, because those of us that do this for a living, dying is a public failure. A patient dying is a public failure. And by God, that patient isn't going to die. But maybe they should. And so we are now trying to get our arms around it. We have added language to the ECMO consents that say we're going to do this for a specified time, and then we're done. Now, what are we really going to do if the family says, I don't want you to withdraw? I don't know. We haven't gotten there yet. But we at least start that conversation before we put them on the machine. Because the machines don't cure, right? The machines are a bridge to something. This is Lou Del Gurcio. Dr. Del Gurcio was my chair when I was a fellow. And so in 1983, however many years ago that was, 40, I guess, right? 40 years ago, I distinct memory of him being in the ICU and looking at me and saying, you cure more patients with physiology than you do with an operation. And that has been my mantra for the entirety of my career, and the little bit I've got left, it will still be. So I think that this story it's not over. We're better, I think. But we have to prove that it actually saves lives. And there is nobody better suited than surgeons, particularly those with interest in critical care, to figure this out. It's really bedside to bench, back to bedside, right? You notice a clinical problem, you go and you study it, and then you come back with the answer. It's how my career started, it's how it's going to end. Because in the end, we have to be at the right place at the right time. We have to control the technology. It has to be next to the patients. We've got to notice what's different. We can't be bound by conventional thinking. If you say, oh, we're not allowed to, or oh, we can't do that. In fact, you can't and you won't. If we challenge dogma and we work together, then you guys, this is to all you young residents and fellows, this is me officially turning it over to you. It's all yours. Steve, I hope that was something close to what you were looking for. I've really had a good time. Thank you.
Tom, that was a fantastic, thought-provoking talk. I bet there are going to be some questions. So, any questions, Dr. Croft?
Tom, that was a great talk. So, one of the things that we talked about last night was what do you do at the extremes of age? And, we at UF, we have a lot of elderly trauma patients. And surely it's real easy to say, yeah, the 22-year-old that got shot in the abdomen, we're going to, do 90 minutes of CPR and put them on ECMO and Mars and yada, yada, yada. But what do you do with the 80-year-old?
Yeah.
And where do you draw that line?
Beats the hell out of me. Because every once in a while, I mean, you roll your eyes, and every once in a while, they live, right? I mean, we just had this 85-year-old lady came in with a hit by a car, had a terrible lateral compression pelvic fracture. We embolize her, she bleeds. I said, should we pack her pelvis? And I said, what the hell are we doing here? This is crazy. And I said, all right, fine. So the fellows call. I said, well, one more time. We take her downstairs, we pack her. Lady lives, wakes up, gets extubated, and just before I left, completely neurologically intact, she goes to rehab. And I go, shit, now what are we going to do, right? And so I don't know. We struggle, just like you guys struggle. We struggle every day with that because, is it fair to say you're not a candidate for this therapy because of your age? Every other society does. But the United States is the one society, I think, in the world that has refused to say you are not a candidate for fill in the blank. If you want it, you can have it here, right? Beats me.
I want to first recognize Dr. Scalia and just say what a pleasure it is having you here.
Oh, thank you.
I think you're one of those rare individuals that has so dedicated his life to saving lives that we really are blessed to have you here. So
thank you.
I really appreciate you coming down. As you were talking, I was struck by the observation that in lung failure, if you use CVVH, the patients got better. That may speak to your issue around the lungs and they're just a bag of air, some alveoli, et cetera. But I do recognize, and DJ is over there, we've written a lot about this idea of chronic disease.
Sure have.
Immune modulation.
Yep.
And I agree that there is a lot mechanically that can be done up front, but then some patients don't get better. And you had the example of a couple of patients that you used. Is there some role for both the combination of mechanical support and biologic support, whatever that is. Can you comment on that? And I would sort of say the surgeon scientists sitting in the audience ought to, take note of your amazing dedication. But I would also like to put a plug in for the biology of this. 'Cause I do think
Absolutely.
it's important.
I have to tell you, I said this is what I'm going to talk about. And then I got off the plane and I said, I'm going to Gainesville to talk about organ failure. How stupid can you possibly be? Yes. So there are a whole bunch of ways to look at this and modalities you can use to treat it. And you guys have written the book on sort of the biology and how to approach this. And what's the answer? The answer is clearly that there are going to be some people that get well with this and some people. And what's that going to be about? Well, it's 2022. So the answer is always it's the genome, right? The genetics determine how you're going to respond and maybe what therapies will work for you. But until we can harness that or at least understand it, it seems to me that having that menu of options and knowing that you have a bunch of different ways to approach this, at least in my primitive understanding, is sort of the way that I try to understand it.
Tom, can I ask you a question about your lung rescue program? When you have a call from out in the state, we've done everything we can for this guy. He's not doing well. Can you help us? Do you have a specific team that will go out and cannulate the patient, place them on ECMO before they're brought back in? Does your shop do that? Or do
Yeah,
you work with others?
we do. It's complicated to put the machine on the helicopter and fly out. It's not impossible. We've done it more than a couple of times. Maryland is it's not that big a geography, nowhere near the size of Florida, as I finally realized driving across the state a bunch of times this week. But the beauty of it is that there are mountains in the west and water in the east, but the helicopter flies over both of those. So it is from the furthest place in Western Maryland to the roof is 40 minutes. And so we'll do anything, right? We'll just make this up, but we have a helicopter, we have a transport vehicle, we have portable technology. And so I'd prefer to bring the patient down before they completely go to hell. And we're doing this, just as they're getting ready to arrest. But we will go out and cannulate them in the referring hospital and bring them down. And we have a cannulation team. But frankly, the people that do all the VV cannulations is us. And so we just, there's always somebody around. If there isn't, my home is almost 3-minute drive from the hospital. So, all right, I'll come call you. I'll let you take the ride on the helicopter, and because I'm afraid of heights. And so you're fine. But we'll do that. Yeah.
Dr. Scalia, wonderful talk. Could you comment a little bit on the article your institution published on the cost effectiveness of your critical care resuscitation unit?
Yeah. I had this idea, and without simplifying it too much, we had these beds. So I called the CEO, oh, that's me, and said, what do you think we should do? So I said, I've got this cool idea. Let's do it, right? And I was there, Karen, I sold it to Karen, and she said, all right, we'll get the nurses. And it just made so much sense. In the year before we started the CCRU, the most common reason that the University of Maryland lost a patient was lack of an ICU bed, right? Because they call and say, oh, yeah, we'd love to bring that down. And look around, where the hell are we going to put them? Oh, I guess we'll send this person out. Well, now we need a bed for that person, right? So, and the referring hospitals got pretty smart. So when I would say, yeah, I'd be happy to bring that patient down, they said, I want a bed assignment. Which bed? And when I'd say, well, we're working on that, they'd call somebody else. And so we didn't like that, the fact that, because we believe we're arrogant enough to think that we're better than everybody else about taking care of sick people. And so I said, how can we fix this? And we can fix it by having a place. And we really just took all of the concepts in our trauma resuscitation unit and we took it upstairs. And what we did is I brought you a little bit of the data, that we were able to cut the time by almost, 40%, 50%, because we always had a bed. And we just said, fine, come on down. And we were able to, the people that benefited the most from this were the cardiac surgeons. Because those dissections, come on down, right? The people with cardiogenic shock, come on down, no problem. And these EM critical care people that we have up there, these guys are unbelievable because we cannulate for VA and VV ECMO there. We put intracranial pressure monitors in there. We have ventricular support devices up there, and they don't, do all of it by themselves, but they know a lot about it. And so we'll get them, we'll get the patients tucked in, and then we'll say, okay, they're going to the operating room, they're the next case, and they fire down. And it's just this, it's like this little city, right? That just kind of does that. And it's, to me, it's if you want to go into the referral business of taking care of sick people, it makes the most amount of sense. And did I say, it's right, it's only 6 beds. If you're efficient with the beds, the patients come, the patients go, the patients come. But of course, what happened, I'll tell the truth here, Phil, what happened is we ran out of beds to put them in because we brought so many transfers in. And so now we're going, all right, yeah, we can get them in, getting them out, a little more complicated.
Any questions out in Zoom land? Go ahead and chime in. Tom, thank you so much. That was a fantastic lecture.